Hopefully people can hear me. Let me know if I also might have my, no, I'm fine. Can somebody speak up and say that they can hear me? Okay, good, thanks. We are using Teams today instead of Zoom, just to see, because that way I can invite, whereas Zoom, we have to have somebody who's actually a faculty member at Texas A&M create the invite. So hopefully this format will work for everybody, but I'm realizing that the one of the main differences that I have to allow everybody to come and accept them into the meeting. So because they get put in a waiting room first. And that's probably just the way I accidentally set it up. So while I'm doing that, and I also need to make sure you guys know that it is being recorded. Sorry, that is my dog at the bottom of the desk. And that we are waiting for Friendship Hospital folks to arrive for the clinical portion of the case that we're talking about. Okay. As people are joining, we are waiting for our clinicians that are going to discuss the case. And if you guys do have preferences about this format versus Zoom, please let us know so that we can make adjustments in the future as well. Okay, let's see, anybody else that needs to be let in? Jessica, how did you get in here? I didn't even let you in.
I think you have me as some sort of admin or something, because it also gives me the option to let people in. So I can be watching that.
Perfect.
Yeah. So I can be your room monitor.
Thank you. I definitely need that. Okay, and can you text JD and make sure that they are going to be there to discuss the case?
I will do that.
Okay. So as JD is getting ready to join, Dr. Foster and his team, which are from Friendship Hospital, Friendship Animal Hospital, they are...
I think that's them. I think they just came in.
We have one very interesting case today. I don't even know if I will actually have time to do a gee whiz at the end because the case today is quite interesting. And plus it's December, so we'll probably, if we get done with the discussion early, we get done with the discussion early. We are set to also have this rounds in January. Again, it's the whatever day is this, the third Tuesday, is that what it is? The third Tuesday, which would be the 16th, at this time point at 1 p.m. Eastern, 12 Central. And I will also send out an invitation to ask you guys to volunteer to discuss cases. If no cases are suggested for discussion, then the rounds are canceled. And Friendship Animal Hospital has been on the ball, and they basically have done the last 3 cases. Granted, they do more biopsies, I think, than any other practice. So maybe it's just a numbers thing. However, I would like to give them a little bit of a break and have other people participate for presenting cases. And again, pathologists can also present interesting cases that they might have had. I know some people that are on here that are pathologists and not necessarily clinicians. It can be multiple different ways of discussing cases. I just want to make sure that it is a group effort and it's not just me lecturing at you for an hour. So that's kind of the goal there. And then my last cleanup point that I always mention is that if you realize you have not been invited over haven't had any kind of communication from me within a month, please reach out to me. These lists occasionally get redistributed and I have no idea, but people eventually randomly will get knocked off the list, off the distribution list. Dr. Hokamp herself, even though she is at Texas A&M, has been knocked off the distribution list. So if you realize you haven't gotten an email from me within a month, please reach out and we will make sure we add you back to the list. Okay. Friendship. Do you guys want to start talking about this very interesting case that we have to discuss?
Sure. Can you guys hear us okay?
I can hear you great. I don't know, do you want me to give you permission to share screen or as well?
I think I'll just chat. Steph right now literally has her hands in a dog's urethra on the other end of the room, so I think
wait, what?
Yeah,
That's
she's
a big urethra.
Well, you know, it's Steph has very small fingers, so that it's trying to see if we can. If you guys want to see the chaos that's happening here,
we want to always see.
Yeah.
Hi.
There's Steph catheterizing a dog on the other side of the room. So.
I mean, this is nephrology in action. So
Yes.
I'm gonna mute myself, JD. And obviously, once we get to the point where but I think the clinical history is incredibly interesting because we've talked about this particular scenario in the past, and we almost didn't even biopsy the dog. So.
Yeah, it is. Yes. So this is Dingy. Dingy is a wonderful little lady. She is owned by a veterinarian, and in fact they say that she's the mascot of the hospital. So when they called us to see if we could help her, they called and they said, we need help with our mascot. And our reception team had no idea what to do with that. Like they thought someone was calling about some stuffed purple animal that was their mascot. So it took a little bit of understanding, but we finally got Dingy over here. So Dingy, it underwent bilateral thyroid and parathyroidectomy for what ended up being a thyroid carcinoma, and started receiving chemotherapy for that. She received, I think, 2 doses of Palladia and I think 2 doses of doxorubicin as well too. And then she started feeling a bit crummy and became azotemic and developed an acute kidney injury. Now, luckily, we have labs that went back that showed at the time of the surgery she had very normal kidney function. So she absolutely had an acute kidney injury and was sent to us for management because she was feeling pretty crummy. So she came to
thyroid carcinoma, not parathyroid carcinoma, correct?
It was thyroid. Yeah, it was thyroid, and just the parathyroids were removed along with the bilateral thyroid. Yeah. So she was receiving calcitriol and Tums and therapy to help control her calcium, and was mildly hypocalcemic. But she came to us, and she was not as crazy azotemic as you would expect, but she certainly felt pretty crummy overall. She wasn't eating. She overall felt lethargic, and she was hospitalized and was overhydrated with the IV fluids. So that was another big component that I think was contributing to her feeling just so terrible, was the edema that she had. So when they called me to talk about referring her over, I said, yeah, let's get her over here. Do you guys happen to have a urine on her? Have you checked for infections since she's been having chemotherapy? Have you looked to see, is this dog proteinuric? And they had not checked a UPC at that time. But I said, send her anyways, because her creatinine was only 5.4, but her BUN at that time was 168. So she was acting more like a BUN of 168 and feeling pretty crummy overall. So we started dialyzing her, and we treated her over the course of maybe 2 weeks or so. And she started regaining kidney function, and we were able to graduate her off of dialysis. And we were very pumped for that. Based upon her history, and once we talked to them, they grabbed urine on her, and her UPC at that time was that the 19, Steph? Yeah, that was a UPC of 19 with this acute kidney injury that she had. So we were concerned that she had been on Palladia, and we were blaming that drug. That was our presumption, not only with the rapid onset of proteinuric acute kidney injury, but also as time went on and she hadn't received any other doses, she was getting better. And so the discontinuation, we were seeing improvement. And with other tyrosine kinase inhibitors, I believe it's just masitinib that's been reported in veterinary medicine, where we've seen proteinuria and podocytopathy associated with it. But that was our presumption. We were thinking that she was going to have a podocytopathy, essentially like a minimal change disorder associated with her likely blaming the Palladia, and stopping it, treating her, getting her over enough time was going to be enough that she was likely going to get better. And so that was going to be our game plan. The owner being a veterinarian, we talked to him about biopsying for confirmation for that. We had started her on prednisone throughout the time course we were dialyzing her, again, under the presumption that she might have a podocytopathy, and in general, minimal change disease can be very, very responsive to steroids. We actually just rechecked our last dog that was diagnosed with minimal change disease just earlier today. This really young dog who went from like UPC of like 20 something to 1 with just steroids alone. So it's one of like the best diseases that we can manage. And so we'd been treating her for it with steroids, and the owner was still on board to go ahead and to biopsy her. So we did it the day that we were removing her catheter. The other thing that is a little, I wouldn't say it's unusual, but was just pretty impressive for Dingy, is that after she had her catheter placed, we improved her overall level of edema with the dialysis and the ultrafiltration that we were doing. I think we were taking off, the first treatment, I think we might have taken off a liter and a half or so of extra fluid that she had retained. But after we had the catheter in place and her edema was better, she developed precaval edema. So just her face was significantly swollen. And that is something we can see. And we usually worry about clots around the catheter. And so we had put her on anticoagulation as well, too. And when we removed her catheter, we actually did it with an angiogram for just sake of interest to see. And it was really remarkable that in her cranial vena cava, and actually the catheter was in her caudal vena cava, essentially all along the catheter was just this super narrowed space. So there was a clot or fibrin sheath, or maybe a combination of both, that filled her entire cranial cava. And the only contrast we could see getting through was the pathway that the catheter had sat in. So pulling the catheter made her a lot better and led her face to become normal once again. But certainly she was very, very hypercoagulable, a bit more than what we expect just for many of our patients that we're treating with acute kidney injury. Maybe about the level for what we see for proteinuric patients having AKI, but it was still a very marked effect that we saw in Dean. So we had treated her to the point where we could stop her dialysis, and we biopsied her and pulled her catheter on the same day.
Okay, so before we start, JD mentioned one drug that is reported in veterinary medicine to be associated with podocyte injury. I guess one class of drugs. So tyrosine kinase inhibitors. The story behind that, and I think all of the case reports have been at least through the IVRPS. Sorry, I have a dog on my lap because she's whining otherwise. But the story behind that is that the drugs which are helpful for tumors such as mast cell tumor, they were even noticed during preclinical testing that some of the dogs would become proteinuric. And they did not ever do tissue analysis when they were developing the drugs. So I think even the safety information indicates that if you should monitor UPC when the dogs are on that drug, and then if they become proteinuric, then you should just stop the medication and kind of do a drug holiday, and they will probably go back to normal and not be proteinuric. So when it got out into being used as an actual medication, we had a few cases that have occurred, and they have taken a biopsy sample, or in one scenario, they took an autopsy sample. And we saw severe podicate injury, which is characterized by complete effacement of most all the foot processes, and then really nothing else going on with the glomerulus. In at least one of the case reports, I think it's the one that we did from the cat, we were able to show that but after stopping the drugs, the UPC returned to normal. And so it does fit into this kind of disease category, which is podocytopathy or podicate injury. And in humans, the kind of old school name for it is minimal change disease. And it's minimal because on histology, you really see minimal lesions. You don't see a lot of significant glomerular damage. So that's one thing. The other thing is the dog was also on doxorubicin. So for anybody, can anybody put in the chat what doxorubicin is associated with when we're talking about rodents? What region of the kidney does doxorubicin cause injury in when we're talking experimentally in rodents? See if anybody knows that. Or anybody want to speak up? I'm looking to see who my pathologists are. Peter, do you know? Okay. Nope, trying to figure it out. Okay. And I think Haley also, no, oh, okay. So doxorubicin can cause cardiotoxicity when we're talking about dogs. Now, when we're talking about rodents, it actually can damage their podocytes as well. So there is an entire set of experimental ways to damage rodent podocytes so that we can use them as models of either minimal change disease or focal segmental glomerulosclerosis. So you use that as a model of podocyte injury for, I don't know, whatever, maybe we're going to test a drug that's podocyte protective. And so one of the mechanisms you can damage podocytes is by using doxorubicin. And that happens in rodents, rats, and mice. In mice, it actually can be, they know the genetic predisposition of like what makes the podocyte more sensitive. And so it's interesting because it is a damaging molecule drug for rodent podocytes. It's never been shown to cause glomerular injury in humans or dogs because we use doxorubicin a lot for a lot of our chemotherapies. And so it is very rodent specific that it would damage the podocytes, but hey, it's a drug that hits the podocytes or that has the potential for hitting the podocytes. And so this dog was on both of those drugs. So that's my little kind of blurb of, I didn't think the doxorubicin was going to be playing a role. And then I will spoil alert, it doesn't play a role in what this dog ends up having, but always being aware of what medications the animals are on is incredibly important because especially when in a scenario like this, they got the drugs, they got 2 courses, and then they eventually went into an AKI. For a lot of biopsies, when I get biopsy samples from the hospitals that use us frequently, they're very good at telling us every single medication that the animal is on. But there are plenty of cases, there are a couple of hospitals that I'm thinking of directly in my mind right now, which will just send us the tissue and then maybe just the UPC and the creatinine, and they don't tell us anything. So, which can be frustrating. So just be aware that it can be, you always have to go back and say, okay, I need to make sure that this patient, is being treated with chemotherapy or not. Okay, so that's my little diatribe there. I'm going to show you some slides in a moment. So you did the biopsy at the same time you pulled the catheter, and there was some coagulability around the catheter, correct? JD, that seems to be screen. Let's see which one I want to do. This one, I think. Is that the one I want to do? Let's see. Bear with me for a moment. Okay, you guys are seeing that. No, I want to, oh, hold on. I need to share a different one. I apologize. Stop sharing. Share. I think it's going to be that maybe. Let's see about this one. Oh, no, it's telling me I have to go give permission. Okay, not going to do that. I'm going to do it a different way. I apologize. I think it's mad because I haven't given it permission to use that app on Teams. So instead, I'm going to open up the report really quick and just get to the photos.
Rachel, I moved it into a different folder. You want me to move it back to the pending cases?
No, I've got it. I have it open.
Okay.
And you also got urine on this, and actually I haven't seen your SDS page report either.
I just submitted it. I just sent it out this morning, and it's in the folder as well.
Yeah, it's just taking a while to. Okay. It does not want to open the page. Can you open the final report?
I've got it open.
Okay. Can I let you share the screen so that we don't waste more time?
Yes, ma'am.
Okay, so I'm going to stop sharing. Oh, you can share then. Okay.
Where would you like me to?
Just go to the photos first and kind of zoom in, and I'll just talk about the lesion. So, yeah. And in the meantime, I'll figure out how to make sure that the digital slide scanner has permission to be shared. So, okay, so JD and I were on the minimal change bandwagon. We were like, well, we know the dog got a drug that hurts podocytes. We probably won't see anything on histology. It's just maybe we'll see a few podocytes that are injured. But hopefully, all of you guys are seeing that the glomeruli do not look normal. They do not look minimal change. They have moderate to maximal change.
I said change. Sorry, I'm going to mute myself.
So here we have images from one of the glomeruli in the different stains, and every single glomerulus looked like this. This was not just a focal lesion. This was diffused throughout the core, and I think the core had like 12 glomeruli. And so on H&E, you in the top left, if you can make that just a little bit bigger, Hocamp, you can see that there's a lot of kind of pale pink material here. She just dyed it blue. I don't know what she did there. That's fine. There's a lot of like pale pink material, and it's in the capillary lumens. Now, Hocamp, if you're going to be good enough to point out a red blood cell, that would be great for me. This is kind of fun. So you can see all of those. That's what the red blood cells look like. That's how they're staining. They're staining bright red. So all of this other pale pink stuff is not blood. It's some other kind of material. Great. And you've circled one right there. So there's a little like coagulum, a clump of something that is kind of pale pink staining. And then if you then switch over to the PAS, which is on the next kind of over there, now we're looking at the same material, and you can see it's bright pink. So whatever that clumps of stuff that's in circulation is bright pink. A PAS stain does not stain the red cells. So a PAS stain is going to have like kind of a pale pink tinge to the red cells. They don't look red on a PAS. So we really can't figure out what are the red cells here and what is this other material, but we can see this other material is bright pink. The other thing is that the capillary lumens, especially that one up at 12 o'clock that's kind of almost close to being a synechia, it's thicker than normal. It is probably twice the thickness of what we would expect. It's a little bit of mesangial hypercellularity. In some regions, we have about 3 to 5 nuclei, so that's a little bit too much. And then, Hocamp, if you can go down to like 6 o'clock on that glomerulus, there's, yeah, right there. That's a big podocyte. So the podocytes aren't happy. That's definitely true. So that's a big podocyte that's kind of like his nucleus is very, very far away from the glomerular capillary wall. If you can go to the trichrome.
This thing right here, that guy, or?
Yeah, that guy, where your cursor is right now. And hopefully
right
I'm seeing the cursor. That right there is a parietal epithelial cell, but then one next to him is the podocyte with the pink stuff in it. Yeah.
Yeah. Okay. I'm gonna see if I can make it a hand. Ooh, yeah, there's a hand now. Can you see my hand? Okay.
You and your tiny hands.
Gotta have the tiny hands. Okay.
Okay, so if we can go to the trichrome. And so, as I'm saying, every single glomerulus had this stuff. So the trichrome, now we're looking at that stuff right there perfectly that's being circled right there. Now it's kind of pale, peachy. Sometimes it gets a little bit like off color white or material. I think in one of the areas, it's just kind of a mixture. It doesn't look bright red. You can see the things that are bright red in there are the red cells. So the red cells are bright red on a trichrome stain. And then if you go Hocamp to like kind of 3 p.m. on that glomerulus and you see the little red dip dots, yeah. So yeah, right there. That's a podocyte that has protein reabsorption droplets. So he's got a lot of debris that he is kind of eating up from the glomerulus, probably stuff that got across the glomerular basement membrane. So we've got podocyte injury. We have this weird kind of in circulation material that's bright pink with PAS, kind of pale peachy to like light, whatever, gray. I don't even know. They kind of got, it's a mix of colors on the trichrome. And then we have thickened capillary walls. And then this, kind of like patchy hypercellularity as well. And then if we go to the Jones, now the Jones is a silver stain and silver binds to basement membrane material. So it's going to bind to glomerular basement membrane material. It's going to bind to tubular basement membrane material, and it should bind mesangial zones because all of that is the same kind of matrix. So the GBM and the mesangium are very similar matrices. And so it should label mesangial regions as well. And you can see the little kind of pale gray stuff that's in circulation. All of that stuff is that same coagulum of material that we saw on the other stains. And then the capillary walls are thickened. This JMS tells us that it's thickened. We will look at that in a moment, Peter. And so we can say that the capillary walls are thickened and that they have double contours. So we see a dark region, we see this kind of pale gray area, and then we see a darker region as well. I think you can kind of see that on the capillary that's at noon. You have like a couple of those. So you have like a line that's dark, a little bit of gray, and then another line that's dark. So there's something weird, again, probably remodeling of the glomerular basement membrane. And I think, Peter, what you're asking, there are things that we're going to be looking at, and I think they're better just shown in another trichrome. So Hocamp, if you wouldn't mind going to the other trichromes on this, I think we only have like one more good one. Oh, that is the other stain. So skip that stain right now. So in this scenario, yeah, I think here I would only say that these glomerular basement membranes are thickened, and maybe that last trichrome had something that made me suspicious for deposits. It might be on the, I think this case had a lot more images than normal. But so immediately I texted JD and I was like, this is not just minimal change, there's something going on. And I think the GBMs are too thick. I think there's something in circulation. I don't know what it is. And so there is a very recent publication, JD, I think it was from this year, right? That was basically, what was it? Circulating fibrin for in glomeruli, like fibrin thrombi within glomeruli.
Yep.
Eat and drink pet podocytes. What are you doing, Hocamp?
I was replying to Peter.
Okay, so so there is a recent publication that looks at circulating fibrin thrombi inside of glomeruli as a case report, and so based on that possibility, We went ahead and stained for fibrin thrombi, or sorry, fibrin itself. Now, to be clear, trichrome can label fibrin, and trichrome should label fibrin, especially like when you have like a region of necrosis, whether it's in a vessel. Sorry, my dog is too cute. I can't help it. Whether you have a region of necrosis within the glomerulus or within a vessel, it should be bright red. So fibrin will be bright red to almost like a bright orange, on a trichrome stain. So this is definitely not staining in that manner. But we did a Carstairs stain and we did a PTAH. The PTAH, you're right, it didn't look very good. And then the Carstairs stain, that should show fibrin and red blood cells as bright red. So that's how it's supposed to look. And if you can see in that that capillary loop that's kind of at 2 o'clock, it's kind of pale. It's like orangey. It's not true like bright red that fibrin should be. So it doesn't really fit with that case report either. But we were really lucky because we knew we were going to get EM on this and immunofluorescence. So I think I can start to do that. So I think you can stop sharing HoCamp and I can share the images. Let's see. That's what I want. Share. I will have to, if JD can put it in the chat, or maybe HoCamp, because I know we were texting about it. I think it was a JVM paper.
Yeah, I have to look it up real quick.
Okay. You should be seeing something that has the file of the case. Are you seeing like a OneDrive image?
Yes.
Okay, perfect. Okay, so we got the EM and we got the immunofluorescence, and I think I'm gonna start with EM because it's kind of cool. So, hopefully they will work. You know what? Oh, there it is. Okay, so they had a good EM sample. I think it had 3 glomeruli. And you're already going to pick up some electron dense material within the mesangium and also within the capillary walls. And then that's kind of a very prominent lesion, and it's going to be present in every single glomerulus. The other thing that is pretty striking to me is that the podocytes are really raggedy. They don't have good foot processes. They have this kind of like microvillus change to their cytoplasm. I think in this area, we completely have lost our podocytes. So we even have podocyte detachment. So we have hurt our podocytes. We have electron dense material inside mesangium and also within the capillary walls. And then also the endothelial cells are likewise very damaged as well. So they will see a lot of examples of endothelial cells where they've lost their fenestra and they're basically just very swollen and almost like protruding into the capillary lumens. So here's another image of the same glomerulus, or maybe even a different glomerulus. But again, we have these electron dense things within the glomerular basement membrane. So when we start to look at things like this, there are 2 possibilities. One is that they are immune complexes, and the other is that they are hyaline material. And then I guess the third possibility is that it's both. There's a mixture of hyaline. So hyaline is plasma that has been pushed into regions it shouldn't be. So if you push plasma into your GBM, you could have this electron dense appearance. But you could also have admixed immune complexes in that scenario as well. Again, look at the podocytes. There's a lot of microvillus change to their cytoplasm. And they just look, again, very raggedy. They don't really have a good normal structure where they look like they have an octopus with all the arms coming out of an octopus. Okay. This, again, we have more electron dense material. You guys are hopefully seeing my arrow now that I don't have to tell HoCamp where to put the arrow. These are circulating red cells. So we have 2 red cells that are out here. They are this also could be red cell material. So if you have severe enough endothelial cell injury, you can kind of bleb your red cells into the capillary wall, which looks like what's happening here. I can't verify it. I'd have to make sure that that's truly like red cell cytoplasm, but it looks like that's what's happening. We have these circulating macrophage, probably lineage cells, because they have a lot of vacuoles and it looks like they're phagocytizing a lot of things. So something is in circulation that is eating up a whole bunch of stuff. We have, again, the electron dense material. Okay, I'm going to skip that one second, skip the next one. I know this is where it's going to get interesting. Okay, so then these things here, which are electron dense deposits, are much more consistent with the shape and the appearance that immune complexes are. When it's kind of just like a blob, and it has almost like little tiny vacuoles in it, then that would be more consistent with what hyalinosis shows. But when it's kind of irregular and even has a halo around it, then it's usually what immune complexes will look like. So again, we're seeing a lot of those immune complexes. They're beneath the endothelial cell. So here's an endothelial cell, and we have all of these immune complexes hanging out here between the endothelial cell and the glomerular basement membrane. That, again, I know this is just me having looked at a whole bunch of cases, but in knowing what plasma should look like, this is likely one of those big globs that is circulating that we saw on the histology. So it has kind of almost a well-defined border. It has little tiny vacuoles or electron-lucent foci, so that's often what hyalinosis has or plasma has. It is in circulation, because you can see here is our capillary wall. I'm outlining the capillary wall. Here's endothelial cell right here. And so this stuff is actually inside the capillary lumen. So this is probably one of those big old globs that's in circulation. And based on its ultrastructural appearance, it resembles plasma. Plasma, again, another little circulating plasma glob or coagulum, I think is how I described it in the report. There are some admixed cells. Some of them might even be monocyte or even polymorphic nuclear lineage. But there are things that are admixed with these coagula in circulation. I will tell you that fibrin, if fibrin was in circulation and it's like polymerized fibrin, that it will look completely different. It'll be quite linear and very dark. And platelets also look very different from these cells. So platelets are not going to look like these cells here. So I'm not seeing evidence of the fibrin thrombi or the platelet thrombi that was discussed for that one case report. Again, a big old glob that's in circulation. And then we have these electron dense material here. And then I'm going to go back. Wait, one more image. Okay, I'm going to go back to the cool stuff. So then if this isn't cool enough, that we have podocyte injury, we have endothelial cell injury, we have circulating globs of plasma material that I have probably never ever seen before in my entire life. We have electron dense deposits. We have remodeling of the glomerular basement membrane. We start to realize that some of these electron dense deposits, and this was present in one of the 3 glomeruli that were scoped, have a structure to them. So this is a very, very, very high mag of, I'm not really entirely sure, but let's say it's a very high mag of just this area, okay? Then when you go to very high mag, you see that they have a substructure and they're linear and they kind of almost crosshatch. These guys are probably coming from the back of the screen out towards my face. So they're kind of running perpendicular, and then they, branch in other, fold in other areas. So, and I shouldn't say branching because none of them actually branch, but they are larger than amyloid. We don't have measurements. I think if we try to officially publish this case, we're going to have to figure out how to do measurements on image J. But they're definitely bigger than amyloid. They're probably on the range of, I would say, 30 to 50 nanometers in diameter. And that's just from my guesstimation. And they are present in many regions. So there's a lot of substructure in these areas. Here's another area where it's coming from the back of the screen towards my face. And then it butts up against a region that is more kind of running parallel to the cut surface. So those things are what we call deposits with substructure. And in humans, we have very few cases, or very few diseases, I should say, that will cause these kind of substructures. One of them is a disease known as immunotactoid glomerulonephritis. You can have fibrillary glomerulonephritis, which is usually a little bit smaller than this. And then you can have cryoglobulonemic glomerulonephritis, which can have a substructure as well. So those are what we would know from a comparison to humans. It doesn't mean this dog has to have that, because dogs can have different diseases than humans. There can be completely different diseases that cause substructure of deposits. But it is incredibly interesting that this dog that has all of the different problems also has a very rare lesion. We have identified diseases with substructured deposits, and it would be less than 0.1% of all of our biopsy cases. So it's rare in dogs. But we do have a few cases that that we know, and actually one of them, which does have immunotactoids, or most closely resembling immunotactoids, was also biopsied by Friendship Hospital. Okay, so I'm going to quickly stop sharing for a second, because I'm going to eventually go and share the IF, but I'm going to review because this dog has a lot of problems. Podocytes, damage, foot process effacement, microvillus transformation, sometimes detachment. Endothelial cells, swelling. They are kind of blebbed into the lumens, so the lumens are kind of collapsed, and loss of fenestra in many regions. We have circulating globs of material that ultrastructurally are most consistent with plasma. It does not look like fibrin. Sometimes when there are entrapped cells or cells associated with that circulating coagula, they look like more like monocytes, or like leukocytes. They do not resemble platelets. So this does not look like a platelet fibrin thrombi in circulation. And we have immune complexes, and some of the immune complexes are crazy enough to decide to become substructured. I'm going to quickly show you the IF to prove that these are true immune complexes, because obviously that electron dense material could be a lot of different stuff, but if it labels in a granular pattern with immunofluorescent stains, then it is very suggestive of to definitive for immune complex disease. So let me share that with you, if I can get that for a moment. Any questions at this point, other than just like, how is this dog having all of the crazy things? Okay, I'm gonna assume no questions. Now I just need to share. This one, okay. Okay, so, let's go to IgG first. There were like 4 or 5 glomeruli on the IF specimen. And so immune complex deposits are discrete dot-like things along the capillary walls. And so you can see these little tiny dit dots, and every single one of those is a deposit. Now, to be clear, there's areas that don't have deposits, but you can clearly see the deposits on many of the regions of the mesangium and along capillary walls. The M is always positive. M is just a big old sticky molecule, and it will stick to a lot of different things. So I'm never really surprised when I see granular or smudgy staining with M. Lambda is our best stain we have that we can use, and all of these tiny little dit dots is evidence that there is an immunoglobulin that has IgG in it. There might be IgM immunoglobulin as well, and the light chain is part of that immunoglobulin. The IgG is the heavy chain, and the lambda is the light chain. So every single one of these dit dots is an immune deposit. And the good thing is that you can compare, and the reason we like the lambda so much better than anything else is that it really does highlight the stuff in the glomerulus, and there's really no non-specific staining. Non-specific staining does not happen in the tubulointerstitium. We kind of feel like the IgG does have like a lot of like kind of linear, splotchy, whatever, gooey staining in the interstitium. So there's a little bit of background that you have to read through when you're looking at IgG. But the lambda is so beautiful. It really just binds to that light chain portion so well. And then IgA, really not much, just a little bit of granularity. And we do have evidence that complement is being activated. It's not the worst case of activation of complement. So we have a little bit of granularity with the C3, and it's kind of segmental in different areas. But a lot of our rip-roaring MPGNs, like when we think about cases that have almost like a Lyme nephropathy or Lyme-associated immune complex deposition, they have like strong 3+ C3. Whereas this one is, I would say 1+. So we're activating complement to some degree, but it's not the worst case I've ever seen. But then the last important part is that if those coagula were in circulation, if they were just huge globs of immune complexes, which does happen, then they should stain positively. So you should see big old globby, like splotchy staining in circulation, and we're not seeing those. So it's not just this huge coagulum of immune complexes. Instead, those aren't really labeling. Yeah, so I'm going to leave that there. Those things that are in circulation are not just big old globs of immune complexes. You can probably see that this is one of them there, and it's not really staining. We ended up having a very descriptive diagnosis for this case, and we've already talked about it for quite some time. I'm surprised it's already 12:45. But I don't know. I don't know what the final cause is. I did recommend that JD try to run a cryoglobulin test to see if maybe that will precipitate. And then that would be more similar to cryoglobulinemic GN, which has never been reported for in dogs, to my knowledge. But I don't know what other testing you guys have done. We've kind of worked this case out over the weekend. JD.
He had to go to an appointment. We did not get cryoglobulins. Sorry, this UCAF is more complicated than expected. We did get that Coombs test that was negative.
Okay.
And her UPC last week was on a 3. Just on the like big per kg of steroids. I'm gonna have him recheck a UPC here in the next week or so to make sure that that's like consistent and not a little bit of an outlier. Because I was about to take her off the steroids, but I haven't put her on mycophenolate or any other immunosuppressive yet. And I think that if she continues to improve, I probably won't yet. And we'll keep an eye on her numbers.
Yeah, I mean, there's a lot of stuff. There's a lot of electron dense stuff in those glomeruli. So, and I think she's probably one of these cases that has an admix of like plasma just being pushed into the glomerular basement membrane, but also having immune complexes. But like I said, it's not like it's really upsetting the complement system. That's just kind of only mildly activated. And we only have one. We're very bad in veterinary medicine. We only have one way to say the complement system is activated, and that's looking at C3 staining.
Yeah, she seems to be generally doing okay right now. She still has an E-tube in. Her appetite's like so, but I think she's historically maybe like a little bit of a picky eater. So I don't know. The owner has been it's nice that he's a vet, because every time I'm like, do this other test, he says, okay.
Well, yeah, it's a very interesting case. And I think I also said if there's any related dogs, like, I mean, just it would be interesting to get samples to save her genetics on her. Clinicians, what would you guys do if you get this like really crazy biopsy result that has all of the different things that go wrong with it? Do you guys have other suggestions? It sounds like everybody's at a loss. Did you guys, did Friendship have more suggestions about what they would do?
Not right now. I think it's kind of making it a little bit easier because she's continuing to feel better, kind of just without us doing much of anything at all. So I'm going to continue to, I am recommending that she not receive any more Palladia. Okay. That's probably the biggest thing. Yeah. Yeah. About all I've got.
Okay, well, I do think that the I think this is a scenario where we have a very complex case that has possible multiple different types of pathology hitting the glomerulus, hitting the glomeruli. So I think the take-home points, even though we don't have a nice, pretty bow to tie around this case, is I'm really glad you guys biopsied and we didn't just assume podocytopathy. There are a lot of lesions, like we've lost some podocytes, so this will probably progress to a sclerosing group type of thing, where there's going to be some degree of proteinuria over the course of this animal's life. So I don't think you're ever going to heal this dog completely and get the UPC down to less than 0.5, but I think you can definitely manage it based on that. If you have an opportunity to get more tissue at some point, whether it's a rebiopsy, these are the kinds of cases that would be amazing for the IVRPS to analyze follow-up from, because I have no idea, again, what those circulating coagula things of plasma are going to do to the glomerulus. So making sure if there is an opportunity, and that, like, those are the cases that we will, I don't know, financially support the from a research perspective for follow-up tissue.
Yes.
And then Jessica, I guess one other thing, and I think I was forgetting this, what did the SDS page show? Because that might be also a better way to monitor, is kind of repeating the SDS page.
Yeah, I just released the report this morning after I had looked at everything that was said about this one. It's severe glomerular and tubular damage. And, you know, I couldn't necessarily have said anything like, oh, well, this is clearly this very weird entity, but it has bands above 200 kilodaltons, at least 2, if not 3 to 4. They're very faint. And quite heavy bands in the immunoglobulin, the IgG, IgA range. So this is definitely something where if we can get some more urine at any point, Friendship is really good about sending follow-up urines from previously biopsy patients, which I super appreciate, and we don't charge for those follow-ups.
Yeah, so
Rachel?
I mean, yeah, go ahead, George.
Just backing up a little bit, you've used the term immune complexes for these discrete dots and things. An immune complex is an antigen and an antibody, and an aggregate presumably of multiple combinations of these attached to one another moieties. But the label is only labeling a epitope on a portion of the immunoglobulin itself, and so it seems to me that although what we commonly see is the discrete deposits that are classic, if you will, and we, I think, correctly, for the most part, presume that they are traditional or classic immune complexes. Any deposit, size, place, or quantity, distribution that is made up of the portion of an immunoglobulin or the whole immunoglobulin that contains the epitope that this probe is recognizing is going to light up. And so that raises the possibility that these are deposits of immunoglobulin derived material that has either stuck to something else or has just stuck to itself enough to get embedded in the matrix of the wall or the mesangium. It's pretty apparent that the circulating globs of stuff are not globs of such things, or if they have, they've become globs in a way that has hidden that epitope. But you know, my musing is to just sort of remind people that although we call them immune complexes, alluding to the entire complex or antigen, antibody, boom, 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 what we're really seeing is the presence or absence of an epitope that we associate with that moiety that is L-lambda light chain or IgG or IgA or IgM.
Yeah, that's a great point. And I misspeaking. I probably make sure that the report reflects that as well. But so when you have electron dense deposits, they can be affiliated or associated with the immune system and not be immune complexes. So in that scenario, it's technically still an immune associated, immune adjacent, I don't know, type of deposit. You can have ones that are only made of complements. You can have complement deposits. Very, very rare in humans, but does happen. You can have, and I think we maybe have seen one case that we believe it in dogs. So you can have complement deposits that are just big old globs of complement. You can have immunoglobulin fragments that get embedded into the glomeruli, and that's what happens in those two diseases I mentioned, fibrillary and immunotactoid. So basically think about, like, let's say your B cells were making bad versions of IgG, like just fragments or portions or not the whole molecule, or the molecule is misshapen. They can deposit, and so they don't have the antigen part. So they are not immune complexes. They are just portions of immunoglobulins. And so that's what happens in some of the fibrillary diseases in humans. The fibrillary diseases that we have seen in dogs, which definitely have fibrils, but are not amyloid. They're too big for amyloid. They don't stain with Congo red. Those actually don't really light up with the IF. And so again, those fibrils they're undergoing fibrillogenesis. There is a protein that is becoming a fibril. The fibril is larger than amyloid in diameter, but we can't figure out what the protein is. So yes, you're correct. They're probably portions of something made by the immune system, but that doesn't mean they are complexing with an antigen. And I'm realizing how bright this light is right now. I'm traveling right now. I'm in Missouri to visit family, and so the place I'm teamsing from is quite bright. So, any other questions or comments? I really would like to get follow-up on this one. If you guys can provide it, Friendship, and we could revisit. I can make a note to myself to revisit this when you have more information, maybe in January's rounds or February's rounds, just to give an update on this very interesting case.
Yeah, we can definitely give you some updates. And then I was just gonna share a really cute photo of the patient. So let me figure out.
You should be able to share.
So,
oh my goodness,
this is her right now. And I think, let's see if it came through. No. So we have some good photos of her when she has like a super swollen face, but she is just kind of like a funny little mixed breed situation.
There's no way you know any relatives at all for this dog?
No, she's a foster.
Okay.
Or not a foster,
Adopted,
like a shelter, yeah. So unfortunately, I don't think we'll find any siblings for her. She has like a housemate, but unrelated.
Okay.
But
yeah, that's always frustrating. Like the things where you're like, this is really cool. It'd be really great to get like some kind of follow up and like know if other animals are having similar affected diseases. So, but we are coming right up on the hour. So thank you guys for joining. And if anybody has any revelations about this type of disease, Larry, if you know how you would treat a disease that has 5 different types of diagnoses and whether you would immunosuppress, please share. I will send a follow-up. I'll send that paper out that has the fibrin and platelet thrombi discussion. And then I'll also, oh my goodness, that is a swollen face.
This is the first picture, like the first night that we sent her home. This is what we got from the owner asking if this was normal.
Oh goodness.
So.
Rachel, I agree. It's a fascinating case. Just really, really intriguing. I have zero insights on what you would treat with.
Well, I mean, hey, at least now we have one more case. I've done like a presentation at ACVP about the fibrillary types of substructured deposits, but I've never written it up. So maybe it's time for a description of all the deposits with substructure, just as a general category. I should say they're in the textbook, they're in our atlas. So it's not like they haven't ever been distributed to people to learn about. But maybe this one is a good one for the atlas to add to it too. Because those deposits with that substructure are gorgeous. They're very beautiful. And the EM scope people at Texas A&M tell them excellent job hooking up. So
Jay will be very happy. He's the one who dove in on that. I'm scared to go up really, really high. And he's like, no, we got to dive in there and look at that substructure.
It's hard. I would say there's plenty of times when you're at the scope and you're like, am I seeing substructure? And you're like, then you're kind of like, am I missing something? So I do try to, every time I have an immune complex case or just regular electron dense deposits, at least 1 or 2 go on high mag, but you can usually get a hint that there's going to be substructure, even at like 5000x. Okay,
yeah, that's good to know as I'm doing these for future.
Okay. Well, I will sign off. Have everybody have a wonderful end of the year and beginning of the next year. Please look forward to an email from me that will ask for people to discuss cases. And also, like I said, even if you don't have your own case, but you're just interested in learning more and you want to talk about a specific topic, we can do some of those things as well. I just need to make sure that it's not, I mean, today I talked for 40 minutes and I didn't necessarily need to talk for 40 minutes. So I try to keep myself under wraps by making sure that other people participate. Okay. Thanks, guys.
Happy Christmas.
Yep.